Next, we are here with Dr. Robert Ferris, who's the director of the University of Pittsburgh Hillman Cancer Center, to discuss the latest in head and neck cancer treatment. Welcome, Dr. Ferris. We're so happy to have you here today.
Thank you, Gina. Glad to be here.
Oh, thanks. So, this year, we're seeing overall survival results of pembrolizumab as a single agent and in combination with chemotherapy in recurrent head and neck cancer. So, what is the significance of these data?
So previously we've seen activity of pembrolizumab and nivolumab in second-line recurrent metastatic head and neck cancer. This is the first positive phase 3 trial in an earlier line of therapy, first-line recurrent metastatic head and neck cancer, where the standard of care, the only approved regimen, is 3 drugs: platinum, 5-FU, and cetuximab, so-called extreme regimen. And so pembrolizumab monotherapy went up against extreme, and then a third arm had pembrolizumab integrated into extreme, replacing cetuximab. So 3 arms, about 800 patients, a positive phase 3 trial. Both arms beat extreme, the kind of current control arm, standard of care. Slightly differently, monotherapy pembrolizumab was better only in the PD-L1 positives. Merck does it with a combined positive score, the CPS 1 or greater. All comers, the entire population, did better when you added pembrolizumab to chemotherapy. So 85% of the population is PD-L1 positive or CPS 1 or higher and can then get pembro monotherapy. In situations where the oncology team feels like the patient needs to have a more rapid tumor shrinkage response, you might use the chemo, platinum 5-FU plus pembro. That had a better response rate, about 35%, whereas pembro monotherapy had a response rate of about 19%. So an earlier response, but the durability in terms of better overall survival came in either arm that contained pembrolizumab. So it's helpful, moves the field one step earlier in disease for IO therapy, and now shows that you can combine with chemotherapy and still get durable benefit.
Great. So you were also involved on a study in which safety and disease control were achieved with adding nivolumab to chemoradiotherapy in patients with intermediate or high-risk local regionally advanced head and neck cancer. So could you also discuss this study?
Sure. And the same theme and philosophy of moving immunotherapy earlier into disease. This is now in the locally advanced, previously untreated stage, where patients who have a survival that's still not optimal. The high-risk HPV negatives have about a 45% 2-year progression-free survival. The intermediate risk, which is the HPV positive, but smokers with heavy tumor burden, have about a 60% 2-year progression-free survival. So still room to improve. And so in the context of a so-called intensification with immunotherapy using nivolumab, this is the RTOG 3504, and we showed safety and durability by adding immunotherapy on top of the standard cisplatin chemo plus radiation, which has some efficacy but really not optimal. And we want to ask whether immunotherapy is safe, which it is, and then does it have better oncologic benefits. It's a small trial, but it sort of previews some of the phase 3 trials that are now running to show oncologic efficacy and hopefully get FDA approval for adding immunotherapy as this intensification. And it's intensification, and yet it's still very, very tolerable.
Good. It's very interesting. Now, we've seen a lot of headway made with immunotherapy in head and neck cancer, but what about any kind of work that's being done with more targeted agents, cetuximab, or maybe any others that are in the pipeline?
So cetuximab was compared to chemoradiation and was shown to have a worse outcome, about a 7% reduction for cetuximab radiation versus platinum radiation. That was the RTOG 1016 trial, just recently published and presented at ASTRO. So the question is, what is the backbone for adding anti-PD-1? In the RTOG 3504, we had a cetuximab containing arm with nivolumab. Actually, I presented that at ASCO 1 year ago, showing that it's safe. And in fact, if you looked at the RTOG 1016, although platinum was superior, it was really only in the performance status 1 patients. Of the 850, 200 of those were performance status 1. If you look at the other 600 that were performance status 0, very fit, robust patients, cetuximab performed just as well as cisplatin. So we know we can add immuno-oncology agents on top of either cetuximab or cisplatin. I think that cetuximab as a therapeutic antibody may be a better partner than chemo, but that remains to be seen. Cetuximab is also being added in Europe in some other combinations with other IO agents. Cetuximab has shown activity with a natural killer cell, NKG2A blocker called monalizumab, and I think we have some cetuximab partners that may allow it to be integrated into future trials in head and neck cancer.
And so that segues nicely into the Palatinus trial of looking at palbociclib, the CDK4/6 inhibitor in combination with cetuximab. So what are your thoughts on this poster that's being presented here?
So I think the CDK4/6 inhibitors are quite appealing. That trial was somewhat small, 30-some patients. So I think it's promising and it's a nice new angle. We shouldn't forget that it doesn't just hit the tumor cell, that in fact the CDK4/6 inhibitors may actually be immune stimulatory as well, and appear to shift the myeloid or macrophage populations, and that may allow cetuximab to be more effective from an immunologic standpoint. I should mention also, while we're talking about new findings, the big phase 3 trial called EAGLE, which was durvalumab alone versus chemo versus durvalumab plus CTLA-4 targeting tremelimumab. So that big phase 3 trial showed that durvalumab is active, but for some reason when you added tremelimumab, it didn't perform as well. In fact, it was slightly worse. So we're not sure what to do with tremi at this stage, but durvalumab is another IO agent that appears to be active in head and neck cancer.
Okay, something to keep a lookout for?
Yes.
Good. So what else can we expect over the next year in head and neck cancer, and what does the future of this disease, the treatment for it, really look like to you?
Well, we've completed a phase 3 trial called Javelin 100, which was adding avelumab to concurrent chemoradiation, that follow-on of the RTOG 3504 that Dr. Gillison, my colleague, presented at this ASCO. And so we now want to see the results in terms of oncologic benefit. That was about a 600-person trial. So that should hopefully get IO approved in the locally advanced setting if it's positive and better than chemoradiation alone. Also, a number of combinations are coming up, small molecules, the TKIs plus IO, such as sorafenib and lenvatinib. Then the CDK4/6 inhibitors, we'd like to see those combined with IO. So a lot of great things happening. We just need to make sure we don't get so excited about the 30-person, phase 1 trials, that we still need to test them, but in really a more rapid fashion, such as neoadjuvant therapy.
Great. Dr. Ferris, you made some really great points today, and thank you so much for sharing your insight on the head and neck cancer landscape and everything that's to come.
My pleasure. Thanks for inviting me.
Sure.